Good morning, all of you. First of all, I thank DPH sir and all the officials of the DPH Icon for inviting me to participate in the DPH Icon conference. And my topic is the last mile challenges in the elimination of filaria and malaria. As DPH sir said in his inaugural session, public health teamwork only will yield good results. The perfect example for the public health teamwork is the control activities of the malaria and filaria so far in the last 50 years. The public health teamwork only led the elimination status for our department now, actually. So, as far as the malaria and filaria is concerned, those are all old age diseases, and particularly the malaria, it causes not only the morbidity and also the mortality. But whereas the filaria is concerned, it doesn't cause mortality, but it causes considerable amount of morbidity as well as the disfigurement and social stigma. So malaria is concerned, see, during the last century, in the 1960s and all, lakhs and lakhs of people have been affected and thousands of people were died. And after the inauguration of the malaria eradication program in India, there are control activities were going on, but some sorts of sense of failure and abandonment of the control activities. There are the resurgence of the malaria cases in 1969 to 2000. So in those period, in the last 3 decades of the last century, the malaria cases have been increased to lakhs in the country, and also thousands of people have died. So because of the improved health technology and improved social economic conditions, housing conditions, and all the other public health interventions, the last 2 decades in this century, there is a drastic reduction of malaria cases in our country as well as the Tamil Nadu. As far as India is concerned, in the last 2 decades, the cases have come down from 20 million cases from 2001 to just 1,60,000 as on 2020. And as far as the Tamil Nadu is concerned, definitely Tamil Nadu is the front runner in all the malaria control activities because of the public health teamwork, as DPH said. And the cases in 1990, we have around nearly 2 lakhs cases in Tamil Nadu, but now it has reduced drastically year by year, and for the last 5 years, the malaria cases have come down below 1,000. Only actually last year, we have around only 300 cases only. And as far as filaria is concerned, Tamil Nadu is already achieved the elimination status. Only the few formalities have to be completed to get the certification. So with this background, I am going for the presentation. It's a simple presentation, short presentation. Next slide, please. So first we will go for the history of the malaria. As I told, prior to 1990, there are no organized malaria control program. Actually, in 1953, the India has launched the National Malaria Control Program, and later it is converted as the National Malaria Eradication Program. And because of some failures in the control activities, and as I said, there are in the early 70s, resurgence of malaria happened, and there is a bursting of cases, malaria cases. Nearly lakhs of cases have been occurring throughout the country, and deaths also increased actually. And in 1976, actually if you take 6.46 million highest cases have occurred because of the post-DDT era, because of the reasons for resurgence is the resistance to the insecticide for the DDT also. That is one of the main reasons. And in 1997, modified plan of operations implemented, and after that only the malaria cases have come down gradually. In 2006, ACT, the drug was introduced in area showing the chloroquine resistance for the falciparum malaria. In 2008, the ACT extended to high-risk PF districts also. These are the brief history of the malaria control program. Next. And as far as the epidemiological types of malaria is concerned, only in Tamil Nadu, actually if you take only 4 types of malaria we are having. First one is the majority of the malaria are the rural malaria because of the living conditions and poor sanitary conditions and all those things. Actually 50% of the cases of in Tamil Nadu are the rural malaria. Anopheles, culcifacies are the major vector for the villages, you know. And urban malaria is another important thing. In the early 70s, urban malaria is also nearly 70% of the cases are from the urban malaria. In Chennai, in Tamil Nadu, about 10 cities are having the urban malaria incidents. So, urban malaria scheme was started in 72 in those 10 towns actually. And another thing, coastal malaria, Tamil Nadu, you know very well, Rameshwaram is one of the classical examples for the coastal malaria because of the diversification of the breeding sites in those areas, mainly Rameshwaram. Now it has brought under control because of some innovative practices in the larval control. And finally, the riverine malaria in the Tenpennai river belt actually, after the Sathur dam has built, the rocky pits, because of the rocky pits in the banks of the Tenpennai, we are having regular cases of riverine malaria. So these are all the epidemiological common types of malaria that has occurring that are in the Tamil Nadu. Next. And actually, this regarding the strategies, actually the NVBDCP, now the NCVBDC is the umbrella program under the VBDC for the integral part of the NHM. And mainly the objective of the malaria control program is the prevention of deaths of the malaria, prevention of the morbidity due to malaria, maintenance of the ongoing socio-economic development. These are all the main objectives. And another important thing, surveillance and case management. These are all the important strategies, main strategies for the malaria control. The surveillance are the case detection. That is very, very important. Early case detection and early detection are very, very important to prevent the morbidity and mortality. And early detection, diagnosis and early complete treatment, that is important. Complete treatment for the both Plasmodium vivax and Plasmodium falciparum. These are all the main surveillance activities that are happening in our state. Next. So, because of the encouraging results of the malaria control, Malaria Elimination Framework has been formed in 2016. The goals of the Malaria Elimination Framework actually to eliminate the malaria, 0 indigenous cases throughout the country by 2030. That is the main goals for the malaria, and maintain the malaria-free status wherever the malaria transmission has been interrupted and prevent the reintroduction of the malaria. That is the very important goal in the malaria elimination. Next. And the objective of the malaria elimination framework, eliminate the malaria from all low category 1 and category 2 transmission states and the union and territories by 2022, reduce the incidence of malaria to less than 1 case per 1,000 population. Now it is around 3 cases per 1,000 population as far as the recent data is concerned. And another important thing is interrupt the indigenous transmission throughout the country by the 2027 and prevent the re-establishment of the malaria transmission by 2030. These are all the objectives for the malaria elimination. Almost we have achieved few of the objectives in our Tamil Nadu. Next. Next. And as far as the malaria surveillance is one of the key factor for the malaria control actually. As far as the surveillance is concerned, 2 active surveillance and passive surveillance are very important. Active surveillance, you are very well know, screening of the 1% of the population, that is done by our MPSWs. And another important thing that is also lacking now, screening of all the AN cases for malaria smear. That is one of the important thing to prevent any maternal complication during the pregnancy. And also fever screening by our hospital, MMU, Hospital on Wheels. These are all the active surveillance are happening in Tamil Nadu. And passive surveillance, 15% of the OPD cases are screened in all the health facilities, including PHC, government hospitals. Private hospitals also screening is happening. And screening of migrant population also being done. These are all the surveillance activities are being done. And the quality assurance, cross-checking of these sites are happening. That is done by the zonal entomological teams, RD office, IVCs at Hosur, and the Central Malaria Laboratory. Quality assurance is the very essential thing because it's one of the important component for the malaria elimination criteria. And vector surveillance and control, very essential. And IRS, one of the important thing, IRS is being conducted every year, 2 rounds in all the 18 endemic districts now. These are all the brief surveillance and the control activities that is being happening in our state. Next. So this is the status, malaria status of Tamil Nadu. If you take, in 1990, we have around 1,20,000 cases in our state, and deaths also happened. Now, because of the control activities, see, gradually the cases have come down, and last year it was only 354. Last 5 years, it has come down below 1,000 cases. Next. And if you take the malaria comparison, ABI and ABER, see, whenever the ABER, you know very well, the number of slides collected in the population, isn't it? That should be around 10 per year. That is the quality ABER. So that is, in Tamil Nadu, regularly we have achieved ABER above 10 throughout the, from 2000 onwards, it's always almost 10 per year. And the API, it has reduced below 1 actually now. It was 0.70 in 2000. Now it has come down around point something actually. So if you see the curve, whenever the ABER is correct, the AP is also very reliable, isn't it? So these correlates the control activity, the quality control activities of the malaria. Next. And the malaria situation, actually regularly, as I told, the ABER is constantly maintained. If you take every year, the blood smear collection is very well maintained actually, except 2020 because of the interruption of the COVID control activities. All the other years, if you take the smear controls, nearly more than 80 lakhs, and last year 1 crore 26 smears have collected. And malaria cases, if you see, total malaria cases also has gradually coming down. Last year, 2022, 354 cases, and last year, 384 cases. And indigenous cases, that is the important thing. See, in the malaria eradication, important criteria is to reduce the local transmission, reduce the indigenous cases for the last consecutive 3 years. That is very, very important. If you see the indigenous cases, actually, the cases are coming down gradually. Last year, only 55 indigenous cases are there. But if you see other words, the imported cases are gradually rising because of the obvious reason is the migrant population, and also screening is taken place. And another thing, PV cases is also coming down. PF and mixed cases are gradually increasing. That is also the reason is because of the migrant population. Okay. As I told, ABER, we are maintaining at more than 10, and API has come down far below 0.001. That is a very clear indication towards the elimination. Next. If you take the stratification of the malaria elimination of the districts, actually in our state, 32 districts have already achieved the status of category 0. Category 0 means districts without local transmission and reporting no indigenous cases for the last 3 years. That is the important elimination status. Already 32 districts have achieved it. Only 6 districts have in category 1. That is the that districts having API having less than 1, but some pockets of the districts are API are more than 1. So that those districts should be brought to category 0. That is the next level aim for towards the elimination. Next. These are all the districts in the category 0 and category 1. Category 1, the Chengalpattu, Ramanathapuram, Thoothukudi, Kanyakumari, Salem, and a major contribution is the Chennai Corporation. Next. And the main next thing is the challenges. The challenges mainly, only 4 to 5 challenges are there. Already we have overcome several technical, parasitical control challenges, vector control, everything we have overcome and achieved this much of status. But few of the challenges still we have to address, and we have to rectify those things to achieve the complete elimination status. The first and foremost challenge is the migration. That is the important thing, the migration of people from the endemic to the non-endemic districts. That is the main thing, actually, the problematic there. Actually, last 2 years, actually migrant screening, we are reporting the Plasmodium falciparum cases. There is one of the risky category, actually, we have reported regularly. The PF cases are reported in our state, and that is the important challenge. Another thing is the shortage of human sources for the surveillance, like health inspectors and lab assistants. Now, as DPH pointed out, the health inspectors number has been reduced from 8,000 to 3,000 now. And another important thing, the urban area, we don't have manpower for the active surveillance. That is also an important handicap in the malaria surveillance. And another thing, insecticide resistance for vector mosquitoes also be there in some parts of the state, actually. That should be addressed in the future. And the capacity building of the malaria for medical and paramedical, that is very, very important. That is not only for the private, even in government sector, the periodical capacity building training for in all aspects of the malaria is very, very important. That means the quality of the smear, right from the quality of the smear, examination capacity, and declaration of the positivity, and RT disbursement, everything is the requiring this capacity building. That should be improved, actually. And finally, the poor disease surveillance in private health facilities. That is one of the important challenge nowadays we are facing. Actually, the passive surveillance is happening in all the government health facilities, right from PHCs till the government hospital, medical colleges. But in private hospitals, we are not conducting the passive surveillance. But even though dengue and other fevers are there, all fevers are malaria unless otherwise it is proved. That is the NCVBDC guidelines. So, wherever, even in the private hospitals, whenever the fever cases comes, the malaria smear should be taken, actually. That is the dictum, and we have to improve the private hospital passive surveillance also. These are all the major challenges we are facing towards the elimination of malaria in our state. Next. Recommendation, as I already told you. Okay. Next. So that's all about the challenges of the malaria. Next, we will take up the filaria control program. Filaria, actually, as far as the filaria is concerned, Tamil Nadu is already achieved the eligibility elimination criteria. Only the documentation and other formalities are there. That should be done, actually. As far as the malaria program is concerned, in 1957, the program was implemented. About 25 control units and 44 night clinics are functioning under the 5 filaria units, actually. Chengalpattu, Chidambaram, Vellore, Kumbakonam and Nagarkoil. Next, the main activities under the Filaria control program, anti-larval operations, mainly the minor engineering works, decanalization, de-weeding, that is all done by the health inspectors and the workers are there. And another important thing is the source reduction. That is also being happened in under the program. Under the night blood survey, that is one of the important thing to detect the early cases, early microfilaria cases in the society and to treat them and prevent the transmission. That is the another important thing, night blood survey, that is also being done by the filaria units. And another important thing, community participation, training, IEC, these are all happening under this program. Next. And actually the filaria elimination in Tamil Nadu is concerned, besides the routine activities, actually Tamil Nadu is the first state. We have started the MDA program in Kadalur in 1995 itself. After that, actually throughout the India, this program has been launched and full-fledged MDA has been launched in 2003 in Tamil Nadu in the 18 endemic districts actually. And we have successfully conducted the MDA till 2014. After that, the parasitical survey has been conducted in 3 consecutive years and we have achieved below 1 microfilaria rate. So we stopped the MDA and we started the filaria elimination activities like post-MDA survey and the transmission assessment survey, TAS. We have completed the TAS also 3 rounds and passed in 2022 and we are eligible for the filaria certification in all the 18 districts. Now these processes are going on. Okay, next. So these are all the 26 endemic, LF endemic districts are there. Next. And as far as the data is concerned, 38 districts and 26 LF endemic districts are there. And the total number of non-endemic districts, confirmatory mapping, 12 districts completed. And the last round MDA conducted in 2014. And post-MDA surveillance activities conducted in all the 26 districts, tasks completed in 26 districts. So these are all the activities have been completed in the state. Next. So innovative steps in the filaria elimination Tamil Nadu, you all very well know, we have established 42 M&F clinic, malaria and filaria clinic in all the GH of the endemic districts. And the Tamil Nadu is the only state giving the financial assistance of 1,000 rupees for all the lymphedema cases. Nearly 8,000 cases are getting every year, every month, 1,000 rupees. The state fund, government of Tamil Nadu is spending around 8 crores every year actually. And DEC medicated salt program has been conducted in the Kanyakumari district in 1995 to 2000 and results in the 95% reduction of the microfilaria rate in Kanyakumari. And we have also, under the state fund, we have distributing the morbidity management kit to the all the lymphedema cases every year. Next. So regarding the challenges in the LF elimination, actually by 2030, the illness is expected to be eradicated as a public health issue. That is the important goal. Actually, now, as I said, all the activities are over. Only the dossier preparation for the assessment by the committee is under process. A committee has been constituted for appraisal of LF in Tamil Nadu is constituted. And as far as the challenges is concerned, poor sanitation in certain areas is still pose a challenge for the breeding of the Culex mosquitoes and the complexity of the disease transmission cycle. That is one of the important thing. And another important thing, asymptomatic carriers in the community act as a potential source of the spread. That is the important thing. The asymptomatic carriers, they will have microfilaria in their blood, but they don't have any symptoms. They don't seek for any screening. That is the important challenge for the transmission. And another important thing, longer incubation period for the manifestation. That is the important thing. Clinical incubation period is very long, months together. Usually it will be 8 to 6 months, but even years together, these years after, the disease will appear after the entrance of the microfilaria in the blood. So longer incubation period is also a challenging period. And finally, the migrant people, like malaria, filariasis is also, the migrant population is one of the posing a major challenge in Tamil Nadu. Last year itself, we have detected more than 100 cases of migrant filaria positives in few of the districts. That is the important challenge. In future, regular screening of the migrant population is the important criteria for the filaria elimination. Next. So that's all about the challenges in the malaria and filaria elimination. Thank you so much.
Thank you, sir. Nice presentation about last mile challenges in malaria and filaria elimination. He insisted on active surveillance as well as passive surveillance. What are the challenges we are having? He highlighted, especially the passive surveillance in the hospital setup as well as private hospital setup, as well as the main challenge is migrant. We are doing the microfilaria night blood smear for migrant population. The survey is continuing, but similarly, we have to conduct a survey for migrant population for malaria also. That is one of the take-home message. Another area is the capacity building for the healthcare worker as well as the entomological team. There is a need of our. We are in the initial remarks by our director. He insists on capacity building and the right people for right post. That is the entomology wing. We are giving that lateral entry to the health inspectors, to the junior entomologists, thereby the DMO like that. Now we are direct recruitment of, we are think of direct recruitment entomologists. We place the policy to government. I request to all, take the message. What are the area we are weak in area? You have to sort it out. There any question from your side? Any question from audience side? Yeah.
Good morning, sir. I am Raghunath, BSc Public Health student from Ramachandra University. So you mentioned surveillance and control measures for rural, urban, coastal and riverine areas. Then what about tribal communities, sir? So on the tribal community ஒரு outbreak வந்தா, so அவங்களோட cultural belief தாண்டி அந்த இடத்துல நம்ம எப்படி control measures implement பண்ணலாம்?
Yes, actually tribal malaria is also an important thing actually. We are actually tribal malaria in Tamil Nadu. Tribally, we are doing the regular surveillance, active surveillance by our health inspectors. And apart from that, some of the people are going for the wood cutting in the forest regularly to the nearby Andhra Pradesh and other places, Kerala and other places. When they return, some of them are contracted the Plasmodium falciparum infections. So regularly, we are identified those who are going regularly to the wood cutting work into the forest. When they return, immediately they are screened by our health inspectors, and if they found any positive, they are giving treatment immediately. That tribal malaria surveillance is happening regularly, especially in the Vellore, Thiruvannamalai and Salem districts, some hilly, some area. Those areas happening regularly, and Dharmapuri also.
Thank you, sir.
We also request sir to present the moderator memento to Dr. Sampath, Additional Director, Communicable Disease. Thank you.